Thanks, Naz. And thanks, Nazia, and thanks, Dr. Lan, for joining us at 6 p.m. this evening. Hope we can help spice up your evening with some quality CPD, hopefully whilst you're having dinner or doing something else and enjoying our series at the same time. So before we begin, I would like to acknowledge the custodians and traditional owners of the land on which we are present today. For myself, that's the Wurundjeri people of the Kulin Nation. And I'd like to pay my respects to elders past, present and emerging, and acknowledge any Aboriginal or Torres Strait Islanders present this evening remotely. We're thrilled to present Telecare's 6th workshop tonight. And tonight we have Dr. Lan and Harsha George joining us today. So Dr. Xinning Lan is a highly skilled psychiatrist. Dr. Lan specializes in anxiety and affective disorders, adult ADHD, and emerging evidence in medicinal cannabis use. She provides comprehensive assessments and develops tailored treatment plans for patients dealing with various mental health issues. In tonight's session, Dr. Lan will be presenting about ADHD, offering valuable insights into the diagnosis and management of this condition. So hopefully by the end of her session, you will gain some comprehensive knowledge and practical guidance from her expertise to effectively address ADHD and support individuals in their mental well-being journey. Thanks, Dr. Lan, for joining us this evening.
It's a pleasure, and I'm genuinely very honored to be here. I may need you, Dr. Wen, to share the slides, just because there's some IT issues. And welcome, everybody. I understand I'm speaking to a cohort largely GPs and psychologists, perhaps. Well, thank you for that. Now, my experience with ADHD diagnosis and management started as a registrar in the public service. Largely because I've got supportive psychiatrists supervising me then, who was supportive of, managing it in the public sector amidst a lot of pressure to treat the risks of anxiety, mood disorders, and schizophrenic form disorders. And now after fellowship, I find myself very interested in treating and managing both public and private, as well as, understanding the RANZAP's position statements. So RANZAP position statement is that ADHD is undertreated in the public sector and underdiagnosed across Australia, actually. And that people who suffer from ADHD have significant psychiatric comorbidities and impairments. The position statement, which I truly believe in, is also that treatment with the right medication, social, psychological intervention brings with it good, resuming of functioning, good quality of life, and good relationships, which otherwise might be impaired. And at this point, I've seen a lot of referrals from my GP colleagues, and I hope also at the end of this session to understand what a good management plan and good reassurance, working collaboratively with my GP colleagues after your referrals. So I really welcome feedback and questions to make my assessment more enriching for you. So I am quite aware that my talk will have to be limited to ADHD in adults, although there are, a lot of overlap between ADHD in children and ADHD in adults. But I'm also very mindful ADHD in children has to be diagnosed by either a pediatrician or a child psychiatrist, and the management ideally should have oversight from pediatrician and child psychiatrists. But otherwise, I'm very comfortable diagnosing, managing ADHD in adults, which will be our main topic. Now, what is ADHD first? That's to me, ADHD. I never knew. I came from a Southeast Asian country, and it was even more underdiagnosed in Southeast Asia. And to us, we really didn't have that concept that it's neurobiological, it's pervasive, it's developmental. In my mind, I must admit, I was not schooled growing up in Southeast Asia about ADHD. However, evidence has started as early as 1902, described in journals, in America primarily. A small group of children, only 43 children then, 1902, start of this 20th century. And the children were, have similar clusters of symptoms: aggression, poor attention. And it was not picked up or treated until 1930s, where a Rhode Island, and again an American research, describes how amphetamine use had a positive effect on behaviorally disturbed children. And ethical standards then were not as strict as they were today. It evolved again to 1950s, where children with ADHD were thought to have minimal brain function just because of poor performance in school, poor attention, poor social skills, but there was no evidence that they are, their IQ could be lower than average or, neuronormal children. In the 1960s, that was where it was first defined in DSM, and be mindful, DSM is described by a cluster of symptoms. Okay, and it evolved again to the 1970s, where the push for general health, healthy living, the diet, the food companies came up about, and there was criticism, there was a pushback about over-medication of children and whether, the ADHD comes from the concept of food allergies, food additives, food coloring. And again, in the 1980s, it was formalized then and given the name ADHD, attention deficit hyperactivity disorder. If you allow me some time to talk about what we know now with our modern science and imaging, maybe a good start could be the neurobiology of ADHD. First of all, there were lots of very convincing big studies that showed there was reduced gray matter, basal ganglia, movement disorder, limbic regions, and frontal gray matter, executive function, impulse control. So there was difference in the thickness of gray matter compared to white children without those symptoms. And that was formalized again, the big studies was a big paper in 2008. Now with PET and functional MRI scans, what we do know today is that there's altered dopamine receptor D2 binding in the basal ganglia, again, movement, and there's altered frontal striatal brain activation during psychological tasks. And there are a lot of models and speculation of how it came about, why these deficits or these changes are noticed. It's, gene studies. There's this big theory: children inherit the genes controlling the monoamine pathways, where dopamine, serotonin, the monoaminase. So the hypothesis, which is correct, is that altered functioning in the monoamine pathways, it leads to change in the frontal striatal cerebellar, again, movement control, the movements, balance control, the circuits are malfunctioning, deficit in dopamine, and there's hypofunction of dopamine pathways to maintain attention, which will be the parietal and frontal. Now, on this same topic, we could imagine that it extends our psychostimulants, our medication, first-line treatment for ADHD. It blocks the dopamine transporter so that dopamine remains in the synapses and increases extracellular concentration of dopamine, more dopamine where there's initially a biological dopamine deficit. Any questions so far? May we move on to the next slide, please? Thank you. There is a lot of studies on the genetics and prevalence of ADHD. Now, there's very high twin studies, very high heritability, 40% to 88% estimates. There is a bit of a gap, but it is statistically very, very significant. There's that heritability. Parents and siblings of children with ADHD, 4 to 5 times more likely to have ADHD. And for me, what it means would be if there's a family history of ADHD, confirmed ADHD, it's a more convincing and more robust assessment for me. The genes, the particular genes in questions, if you could have the name, DRD4 gene, DAT4, all related to the monoaminase dopaminergic genes. But there's one serotonin gene under scrutiny at the moment, the 5-HT1B gene. Children now, there is a study that studied children already with chromosomal deletions or duplicates, and there's more prevalence of ADHD than the general population. Now, if we're speaking of numbers, we spoke, right at the start where the RANZAP position statement is that it's underdiagnosed and undertreated and perhaps even underreported. The prevalence in adults would be about Dunedin studies, a very big study, cohort study done over 38 years in New Zealand, showed that in adults over a number of about 1,060 adults, about 3% prevalence of ADHD. And in children, the same children, same cohort 38 years ago, the prevalence was about 6%. So it was very consistent with what we are seeing right now, which is the numbers wavers between 4 to 6%. What interestingly came out of the Dunedin studies, which really reshaped our ability to diagnose adult ADHD, is that the Dunedin studies, the 3% of adults in adulthood with symptoms of ADHD fitting criteria, 90% of them were not the cohort of childhood ADHD. If that, so it shapes really our understanding that there can be adult onset or ADHD or missed ADHD in the childhood for a variety of reasons. Now, in Congress, I saw a question that was exactly what I was going to come to. So when I attended our recent RANZAP Congress, chairman of AADPA, which I'll get to, Australian ADHD Professional Association, mentioned his youngest patient was 5 years old, his oldest patient was 92 years old, and it's okay to treat, you just have to treat adults over 65 with caution. I would, by the age of 65, they're usually, in a care package, or they're a lot slower, slowed down by the normal frailty of age. So treatment is not as simple or not as, high recommended without normal monitoring, but it can happen. All right. Now, if we could move on to the next slide, please. Thank you. A lot of the studies of ADHD continues into its comorbidity. So 80% of adults with ADHD are disadvantaged with comorbid disorders. So ASD and other developmental disorders, they are 6 times as likely to have ADHD, and very, very high overlap. Pervasive developmental disorders like tic disorders, intellectual disorder, learning disorders, also 3 to 6 times as likely to be comorbid with a diagnosis of ADHD. Now, mood disorders, people with ADHD were 3 times more likely to see mood bipolar affective disorder, depressive disorders, anxiety disorders, and that could be that temporal effect. People with ADHD are more likely, to have poor functioning and to have poor coping, and develop and more higher vulnerabilities to low moods and anxiety and not cope. ADHD is also very highly comorbid with personality disorders, 4 times the risk factor, especially the cluster B's personality disorder, antisocial personality structure, emotionally unstable personality structures, highly comorbid. Again, it could be speculated that there's a difficulty and adversity in childhood. There's a predisposition, to be active and to act out, and it becomes a role modeling, and a habitual, impulsivity. The frontal, the neurobiological vulnerabilities, inability to, appreciate or have social skills, or have the impulsivity control, which are comorbid and lead to, again, vulnerabilities with offending behavior or emotionally dysregulated behavior or self-harming behaviors. But, that all is not lost. I've been reminded time and time again that people with ADHD have a lot of strengths. So they're, usually people with ADHD are very enthusiastic. They're the first ones to think of very novel ideas, think outside the box and be the first to say, yes, I can do it. And their limitations are in their commitment to be able to do a task. But there's, task initiation or, wishing to do a task is there. Highly enthusiastic. They're novelty seeking, which again, leads to their creativity, novel approaches to problem solving. If they're in the right environment and nurtured, their strengths will flourish, and their disadvantage is potentially can be managed with the right treatment. Okay, so all's not lost. I always tell my patients with ADHD, there are strengths and there is hope, and treatment has been shown to be effective. All right, next slide, please. So I would like to talk about the core symptoms of ADHD, and I've attached, I've neglected to attach, I apologize, a table, a very beautifully lined table from Ranzap Learnit, giving them due credit and diligence of diagnosis of ADHD between using DSM or the ICD, but largely psychiatrists can use either. Now, the core symptoms are inattentiveness, hyperactivity, and impulsivity. And some examples of the inattention would be, a good history, which, listening to them would be problems sticking to tasks. They're very disorganized. They start something, they cannot finish it. There's poor attention to details. They cannot multitask. They seem to, the family members will say, they're not listening, you're just not listening. I have to repeat myself, I have to remind them. They seem not to follow instructions, which can be very frustrating. And there's avoidance of activities, which are very mentally taxing, like homework or activities requiring effort, like, reading a paper, reading a book, and there's high distractibility. These are the core symptoms of inattentiveness. Now, hyperactivity, the fidgeting when bored, spinning around, when bored, twisting their fingers, and these are, we all are in an assessment, we can notice how it's different from someone who does not have ADHD, talking excessively or talking out of turn. So for example, some good clues for me would be the teachers, always telling them sit in the corner, or you have to hold the talking stick in order to talk, wait for your turn. Running about when it's more appropriate to be still. The impulsive symptoms, blurting out answers to your questions first, not waiting in turn. They are frequently interrupting or intruding. Now, so core symptoms. Now, the diagnostic criteria is, as according to the DSM, is 6 out of 9 of the inattentive symptoms, or 6 out of 9 at least of the hyperactive symptoms, lasting at least 6 months, and with impairment. The other essential criteria is not just the symptoms, but the impairment. Impairment would be noticed, impairment, difficulties functioning in at least 2 settings, the home setting, the school setting, the work setting. They're all very common. And the impairment, the other diagnostic criteria is that it's not a par for age. So for example, a 4-year-old must not be judged at the level of a 12-year-old. And onset of these symptoms must be evident before age 12. And the reason why they have made psychiatrists responsible for the diagnosis is that it must not be attributed to a current mental illness or, a likelihood of a mental illness. If it's more likely, it must be treated first before the diagnosis can be given. Now, practically, what it means for me would be how I approach the interview. If I could jump the gun on this slide, would be that I would have received your referral. Thank you very much. And if the referral is for ADHD, usually good practice is to ask for as much collateral as possible. There must be presence of a family member, preferably a parent or someone who knows them from childhood, with school reports or, past pediatrician reports would be very, very handy, or work colleagues, specifying the reports, giving the person must be willing for us to, ask the work colleagues, it involves involving someone else. So we will need their consent for a robust interview. And we like to get them to understand before they commit to, the assessment, which could be under 291, it could be under non-bulk bill, non-MBS items. Any questions so far?
No questions so far, but I'm sure there'll be plenty at the end.
All right. Now, the next slide will be the table that I've forgotten to. I apologize. I do not have ADHD, but I have a lack of attention to details. Sorry about this. Towards the end of the day, it was a beautiful table from RANZAP. Again, credits to them. Comparing the diagnostic criteria for ICD and DSM. My preference is DSM. But some psychiatrists, they're welcome to use ICD cluster of symptoms. They're more likely to be diagnosed with DSM than ICD. Just bear that in mind. Now, the referral, that practicalities of receiving the referral from yourself, and then we'll later go on to talk about management. Now, I would really, having done several months in the private capacity after, managing ADHD in the public capacity, where the patient is worked up usually, with a case manager, with, robust history known. I really appreciate the referrals that mentions the specific questions of ADHD, because sometimes the patient, under 291 is a bit of a surprise, come and asks me for ADHD, where the referral was for anxiety and depression. So, it's very, very helpful right off the start to be, clear with the patient, because they may not be able to communicate as well, limited by their own impairment or veiled in their intent for some reason or the other. But I must say, for my colleagues who, were very specific in the referral, that, really adds richness and confidence in our diagnosis and workup. If possible, any childhood history, any collateral sources, so that we know, who to include. And the childhood history could be brief. I've got some beautiful referrals that mentioned, have already had symptoms in childhood, but parents not motivated or unable to seek help because, they were socioeconomically struggling. And that's wonderful. It allows us to understand while we do our own due diligence as well. Sometimes the issue of substance use history, that was a lot in contention, but duty of care and AADPA guidelines would be to mention and understand their substance use history, because it would be in the best interest of the patient. And it will help drive, if diagnosed with ADHD, even so, what would be the best management? Just substance use by itself is not enough to exclude someone from psychostimulants. Oh, fantastic. Thank you, Dr. Wen. Not enough to address, exclude someone from eligibility from psychostimulants, but it could mean very close monitoring, weekly, fortnightly urine drug screens, needs to be done. And urine drug screen can exclude psychostimulant prescribed from amphetamines, methamphetamines class under a GCMS. Okay. Now the current medications, very useful, what they're on, anything, to precipitate manias, for example, Cifrol, or L-Dopa, carbidopa, any antidepressants, anything to give us a clue. Other concurrent health medications. I got a beautiful referral that was very detailed, mentioning a young guy, very clearly has ADHD, but also, abused energy drinks and gave himself cardiac arrhythmia, and so he will need all the right workup. And that was wonderful, beautiful, closing the gap in the level of care that we need, that we could do the right cardiac workup. Physical health issues, again, blood pressure, weight, any eating disorders, all much appreciated. In terms of treatment, here's when I wanted to leave it open to my colleagues, because at the end I will be asking and recommending everyone to download AATDPA, Australian ADHD Professionals Associations. They recently published their guidelines. You could pay $30 for a paper copy, or you could download the online one, giving them your email for free. Very good guidelines for the first time we have Australian guidelines, where in the past, RANZAC relied on Canadian guidelines and NICE guidelines. So it's out, very good treatment options and monitoring options. So it's available, AADPA, download it for free after you give them the email address. But management. So again, I'll have to, qualify that for adults, if given the diagnosis of ADHD, psychostimulants, if not contraindicated, are effective, demonstrates, in conjunction with psychotherapy, social skills training, lifestyle environment modifications, very good return of functioning, ability to work on repairing, any ruptured relationships that they've had, reduces reoffending or offending behavior, and is associated with a lot of reduced illicit substance misuse. And psychostimulants, my personal preference, there's no difference between methylphenidate or Vyvanse, lisdexamphetamines, but I have a lot of confidence in Vyvanse, and I usually give my patients a choice, but I advise them, I have very good experience with Vyvanse. If they have a family member that has, good treatment with methylphenidate class, I'm happy to support them with that. That's not an issue. The at least 6 weeks of trial before we could, and adjusting up to therapeutic dose, meaning up to 70 milligrams for Vyvanse, up to whatever dose it is that they need for Ritalin, methylphenidate, before we could say it's not effective, no substance relapse, good tolerability. And, usually I'm happy to support the switch to the other longer acting preparation, Vyvanse, or to methylphenidates, before dexamphetamine is used. Dexamphetamine is just at higher risk for diversion, but just as effective if used safely. Now there, for someone, contraindication for not using psychostimulants. So at times, while substance misuse is not a contraindication, it's certainly something that we have in mind. Good first lines for the population who for some reason cannot trial psychostimulant. It could be patient choice, it could be blood pressure, it could be cardiac issues as well, or just a choice. Guanfacine, atomoxetine are pretty good choice, and now we have the added option of buprenorphine, very dopaminergic antidepressant that's used in smoking cessation. It will be off the PBS for someone with ADHD, but for the first 13 weeks, if they smoke, I usually like to give them the PBS option and subsidy. And at the same time, I would advise them, see a psychologist for the social skills training, for the all the environment modifications. I'll support them if they're working or studying. I support them in asking their work to support earphones or a private space to do their work. Some extra time if they're studying. Some concession extra time for both exams, for assignments, for extra coaching, at this point, this is. I would just like to encourage everyone, to because I'm very mindful. My colleagues are very experienced GPs. There might be questions that challenges me, but I'm willing to stand and try my very best to problem solve with my colleague GPs. At this point, does anyone have any thoughts or questions?
There are two questions, and then I thought we might launch some of those poll questions that you had pre-written so that we can get some reviewing performance points or hours. But first of all, there's a question from Dr. Adina. How frequent is ADHD in older patients after 60-year-old? Is there any association with the development or delayed development of dementia?
To answer that, I would say it's less frequent. It's less prevalent because of the slowing. But in terms of exact percentage, I'm sorry, Dr. Edina, can't answer that. Can still be treated. Evidence is that I would still give some of my oldest patient is 63 or 64. You do not need a psychogeriatrician to prescribe, but it has been done. And no, but but by itself, depression, personality disorder, and rejection from family members are risk factors for poor outcomes and developmental of these neuropsychiatric disorders in later life by itself, if that makes sense. So I think there could be more disadvantage because the risk factors by itself would mean they're at higher risk already of cognitive dysfunction secondary to the psychiatric risk factors.
Thanks, Dr. Lan. And Dr. Fiona Zhu asked, please give more symptoms of adult ADHD, or I guess maybe I've just located that resource that you had alluded to on the AADPA website. So that maybe that will have a list of quite a lot of the diagnostic criteria there. So we'll have a lot of...
the diagnostic criteria. So how it's diagnosed, a very good, it's more about management, but the symptoms in particular, focusing the psychiatric interview by itself, focusing on childhood, schooling, I would need to know their schooling, what it was like, why did your parents not pick up on it later on, earlier on in life? What did school psychologists say? How did you cope? But I always use a semi-structured interview, the DIVA-2, as my guide. So they don't just fill it up, but it's semi-structured, going through it with them to help me. And that interview by itself is 60 or 70 questions talking about specific symptoms, meaning, do you find yourself not being able to sit still? How do you find yourself in situations where you're bored? Can you watch a movie from start to the end? When people talk to you, what have you noticed? So in the DIVA-2, every question would have been gone through with them as part of our diagnosis, which is why an ADHD assessment needs at least 90 minutes, which is over 2 sessions. And the DIVA-2 by itself, I'll just pull up DIVA-2, which is always used to give you some idea. DIVA 2.0.
Is this the, I think I've just posted a link into the chat. Yes. I believe that's the DIVA-2.
Yes. So yes, absolutely. Any examples, both adulthood and child, are you dreamy or preoccupied? Do you have difficulties concentrating on the conversation? So it clusters, again, the 3 core symptoms: inattentive, hyperactive, and impulsive, okay? Do you find yourself having road rage? Do you find yourself, getting angry with your bosses for no good reason? Do you find yourself always the one that frustrated and leaves the group? Can you do your supermarket shop and tolerate, the noise from the supermarket? So all these are in the DIVA that helps guide us, but it doesn't. So again, we're told very clearly, the diagnostic criteria is presence of at least 6 of the 9 core symptoms and the impairment. For someone who the symptoms are present, but they are not impaired, objectively, collaterally, I would be hard pressed to make that diagnosis, as well as lack of presence of a current mania, current psychotic symptom, or current depression that's making them scattered.
So we've got a couple more questions on the DIVA front. There was one question on the DIVA front. Can a DIVA 2 be done by GP and provided as part of the initial referral to reduce the number of sessions required by psychiatrists?
It will be. I wish. What I've been taught is in a recent Ransack, the psychiatric interview. While I really have a lot of faith in my colleagues, but it helps us, have confidence in our assessments as well. And I feel we're doing our duty, because that could help us understand, their lifelong history. And so at this point, all the major clinics, all the psychiatrist guidelines will be that we are obliged to, go through this semi-structured interview to really understand the symptoms. I can tell you that there's no hard and fast rule saying that we have to, but it's as best practice, as we've been told consistently by AADPA. I would want to. And the question, I will answer. Your such question will probably be driven by best interest of the patient, whether they can get diagnosis more quickly. Is that my understanding? Your motivation to ask this question and help out?
I believe that is the So Dr. Dwyer was saying speed and cost. Yes,
absolutely. How my colleague and myself, one colleague of myself and at Telecare, we are happy to bulk bill again. But I know a lot of my colleagues just somehow do not like to, for some reason, find themselves unable to bulk bill, and I know that excludes a lot of patients. But the 2 structured interviews also affords us the ability to observe them over 2 settings, 1 week apart, 2 week apart, which is also something that will add confidence to my diagnosis.
Thanks, Dr. Lan. And a final question before we move on to some of the polls was, do clients generally need to eliminate other personal psychoactive substance use before commencing treatment with 5-ANTs or similar?
So if they're diagnosed, for the diagnosis, I will ensure or have good objective evidence or collateral that they have not used psychoactive substances in at least the last 6 weeks. Most of my referrals, I've had no grounds to worry or suspect, and very good, collateral sources and, urine drug screens, or very genuine presentation. So that by itself, if I were to give the diagnosis, I would want them to be off substance. And yes, if they have concurrent, use, on the contraindication, the risks are that access, cardiac arrhythmia, hypertension, brain bleeding. I got cut off just now.
I think me too. I think all of us did. Maybe it was my internet. Apologies for that.
Yeah, I'm back online now.
All back. Great. That's great.
Oh, perfect. Yeah. So I've heard the question. I don't know which stage we all got cut off, but in order for the diagnosis itself, I would need very good evidence that there's 6 weeks abstinence of psychoactive substance, plus the risks of psychoactive substance use, especially the amphetamine class medications concurrent with psychostimulants, could be the physical side effects, and which would hypertension, cardiac arrhythmias, brain bleeds, as very rare disorder, the potential of neuroleptic malignant syndrome, depletion of dopamine after a big whoosh, and depletion of dopamines. There's also the risk of then developing psychosis, iatrogenic psychosis, or sorry, I know, give me your brain bleed, or iatrogenic psychosis, iatrogenic mania. Now, thank you for this question, because it again brings to the point. People with schizophrenia, it's still not a contraindication to treat with psychostimulant, but people with, because that's the theory of a stress diathesis of psychosis. People with schizophrenia, high stress levels can get psychosis. However, if we treat using Vyvanse or psychostimulants, and they have good functioning of life, that by itself can help the stress, and in fact could give them good functioning. There's more likelihood of a manic relapse or manic symptoms rather than psychotic symptoms with psychostimulants. So the iatrogenic mania as well is something that we can frequently see if they abuse both the psychostimulants prescribed or concurrent substance use.
Oh, thanks, Dr. Lan. So we might just launch a few poll questions at this stage to give our attendees a little bit of a chance to reflect on what some of the questions that we've just gone, some of the talk that we've just gone through. So first of all, poll question 1. Can everyone see the poll question on the screen?
Yes, Ray, it's visible. Thank you.
Okay, great. Yes, I can see some responses now. So we'll just give everyone about 30 seconds just as a chance to reflect on our discussions. So what is the estimated inheritability of ADHD based on twin studies? So we'll give it another, let's say, we've got about half of participants having responded. Let's give another 15 seconds. Get your last votes in. All right, I think that's tapered off. Okay, so I'm going to show the results to everyone. Dr. Lan, can you see the results? It's so we've got about 15% of respondents saying A, 10 to 20%, 51% saying 30 to 40%, 16% saying 50 to 60%, and 18% of 70 to 80%. And I believe you've marked the correct answer as 30 to 40%, although I do note your slides did show a wide range. Yeah.
30 to 40, I agree with that. Yes.
All right. And then
because of the high variability of, yeah.
Yeah. And then I might just launch a second question, because we've talked about this as well. So which of the following is not a comorbid disorder commonly associated with ADHD? All right, the answers are coming in. All right, we're over the 50% mark, another 15 seconds or so. Okay, so I'll end the poll there. So sharing the results, hope everyone can see it. So there was 13% answered autism spectrum disorder, 10% mood disorders, 11% personality disorders, and also schizophrenia 66%, and that's the correct answer. Yeah, fantastic. All right. Now I believe the third question is also something we've covered, so I'll just run through that as well, giving everyone a chance to reflect and review. Now, which of the following are considered core symptoms of ADHD? A, inattention and hyperactivity, B, depression and anxiety, C, hyperactivity and impulsivity, and D, inattention and impulsivity. "15 seconds, get your answers in. I'll end the poll there. Okay, so we've got 70% of respondents responding inattention and hyperactivity, which is the correct answer. 5% depression and anxiety, 4% hyperactivity and impulsivity, and then 21% inattention and impulsivity. I think this might be worthwhile actually talking, I suppose, about the impulsivity, how core that is, because there was a significant proportion of participants that answered D as well.
Yeah. So primarily it's attentive, I would say there are 3 core symptoms, but the most prominent are the inattentiveness and hyperactivity. And diagnostic criteria asks us for one of the 2, and impulsivity is an adjunct.
Thanks. Thanks for that, Dr. Lan. All right. And question 4, I'll just launch that question as well. When assessing a patient for ADHD, which of the following factors should be considered? All right, we've got answers coming in. Another 30 seconds or so. All right, great. I think we've got a good amount of responses. All right, just sharing the results. So a majority of participants picked the right answer, which is all of the above, which is family history of substance abuse, childhood history and collateral information, and physical health and concurrent medications, all very important. Great. And
now, may I go back to the last question and know?
Oh, yes, sure. Yeah.
Certainly, our colleagues might have been feeling a bit shortchanged, perhaps, and it's not your fault. So DSM clusters hyperactive and impulsivity together. So you need 6 of the 9 core of hyperactive and impulsivity, but really the more prominent ones, we see a lot of hyperactivity. But in adults, in children, you might see more hyperactivity. In adults, it could manifest as impulsivity. But inattentiveness is a separate category of their own.
Okay, thanks.
Sorry about that, colleagues.
No, that's great to clarify that. Okay, and then I think maybe the last question we'll save. I think you were still going to cover a little bit more ground, so I'll save the last one before we keep going with that. Nazia, can you share the slides again?
Yeah, my only question was, I would like to hear feedback from what is a good management plan from, the general practitioners around here. What are some things that you really appreciate in a 291 report back to you? So, I've talked about treatment management, referrals, and the gene studies, and I would like to hear to improve ourselves.
So if anyone's got a burning desire to share what they would like, yeah, feel free to put up your hand. We can see you put up your hand and then let you answer live. Or if you want, just put into the chat and then I can read out the comments as well. So the question is, what would you like to see in a 291 report? Whilst we're waiting for takers, I guess from my point of view, I get quite a lot of 291 reports. And I think the most important thing is how to titrate medications and kind of backup plans, and then also a bit of a discussion around the follow-up that's required, any kind of investigations that are necessary before starting, because sometimes we might not have done the ECG before referring. That's always a good reminder for us to order those tests if we haven't already done it. So we've got one chat item, which is to have a specific medication plan, which is, really important.
Yeah, I usually will give my authority to script psychostimulants, and I will talk about 6 weeks of this at titrated up to that dose, watching out for these symptoms, which I suspect, especially in those with bipolar affective disorder or psychotic illness or substance relapse. And I usually can remark I'm happy to switch to the other class, from lisdexamphetamines to methylphenidates class. But I do have some referrals back with that. A lot of the GPs prefer, they have no concerns, it's just suboptimal response, so they prefer if we help and assist in a decision under 293 for that management change. I usually, while the Canadian guidelines, which we have been using so far, says if there's no presence of cardiac history, an echo is not needed, an ECG may not be needed, but it's very good practice to do so. In some people, where echocardiogram, could even be needed for if they've had existing, ejection fraction issues. I usually will talk about, I would like concurrence of psychotherapy or social skills training under, mental health care plan. And I would have cautioned the family about any side effects to look out for. But usually, if there are such risk factors for, either substance use or bipolar affective disorders, particularly, or psychotic disorders, I will continue care of them for at least 6 months or so, just to, and see them monthly. I feel very privileged, and I bulk bill them, especially if they're rural patients. So, they're quite willing to come back and see me.
That's a really good plan. And so I think no other feedback, but I always find the diagnostic kind of thinking also really helpful in a 291 when you kind of write reports that do mention a little bit about the diagnostic thinking. I think that's always really helpful.
Yeah, absolutely, Dr. Wen. And sometimes it's we find that they're again, parents unable to seek help, but they're horrible, and as a child, but I was struggling, I was working to put food on the table, and the teachers kicked them out of class, and all this a justification for me to support them with the adult onset ADHD. The other issue would be sometimes I have another cluster which I've seen, an older group of ladies who had diplomas in the past, and now they're very motivated to go back to school and do a diploma or do a degree. And the question, I think I have ADHD because I can't perform as well as I did in the past. So if we look at this cluster, there is no childhood history before age of 12. They function very well. They say, I did so well. I don't understand why I'm not doing well now. They are menopausal, which by itself is very disadvantageous for concentration. They're suffering, they're having stress in their life. They're attending school later life. So all this strictly by criteria standards, I would find a way to explain to them why the diagnosis is not met. And usually I break it to them gently, and they take it on board.
Oh, that's good to hear. I think sometimes we do wonder whether we're overdiagnosis, given that everyone we send sometimes ends up with an ADHD diagnosis. So that's really good to hear. And I do appreciate when psychiatrists send them back and say, no, I don't think they have ADHD, which is great. I think that's always really good to hear. So some other comments about 291s. Is it normal for 291 report to have just general suggestions for medication choice without pointing towards one particular medication?
Not in my 291s, and my peers whom, I have a peer group supporting each other for ADHD are very specific about what they would like to start Vyvanse over, methylphenidate class. However, I feel a good report as, Medicare item means I have to give at least a management plan that would at least make the GP feel confident for at least several months. Before review again. And to me, I interpret that to mean, more specificity about what class, when to change, or when to refer back to me. I welcome any referrals back to myself. I would usually also say I'm happy for antidepressants to continue. That's by itself not contraindicated. Antidepressants can be together, prescribed safely with psychostimulants. The MAO inhibitors, different question, but usually I would say I'm not comfortable with the MAO inhibitors unless there's very careful cardiac checks. So specific to your question, not myself or my peer group, and not in terms of the requirements of that Medicare, I think they ask for more specificity. Has anyone, any of the audience and the attendees here ever called the psychiatrist back for clarification? Because I'm extremely happy to be contacted, clarifying questions, when to do, and I can amend the report.
Any attendees have experience with contacting a psychiatrist? It's really great to hear that. I certainly haven't done that myself in ADHD realm, but in other kind of complex mental health realms, I have been able to speak to the psychiatrist, and that's always been really, really helpful. Sometimes even organizing case conferences, particularly for my eating disorders patients. I found that, I found some psychiatrists really responsive and willing to engage, and that's been fantastic. There was another open question about, does ADHD persist with elderly patients? I think we've answered that before, which is yes.
It can persist into life, and done it in studies. It can be missed, it can persist in life, but the impulsivity and the ability to be hyperactive, hyperkinetic reduces.
Yeah, okay.
I'm a 92-year-old is, 92-year-old, the oldest psychostimulant prescribed patient in Australia.
Oh, wow. Okay. It's always good to have a record. All right. I think that's all the questions there are for now.
Thank you very much.
Now, actually, another question has just popped up. Dr. Nguyen asks, is it appropriate not to treat ADHD? Yep. By taking medicines, only psychosocial therapy, and fit them to a suitable career?
Yes, and again, it's a matter of choice. Medications, psychostimulants have been established to improve the core symptoms, while the social, those core symptoms we talked about, while the psychosocial effects helps them retain or regain functioning. But that would be, not the norm. The average patient does want psychostimulant to help them with these core symptoms, and they seek psychotherapy. They have environment modifications. They get schools to give them exemptions, but for some reason, if for some reason they're not suitable, psychosocial intervention, environment modification also, while not as effective, can bring about some improvement.
And Dr. James Jars asked, does patient need to take medication for life, or when do we consider stopping medication?
So after schooling, a lot of the kids will take for their school, get the functioning, become stable. They do not need to take it for life. Take a drug holiday because it prevents, the days that you don't need concentration, don't take your psychostimulants, prevents tolerance building. And a lot of them persist in their 30s. They stop taking when they're in stable jobs. Their relationships are stable. They start to understand themselves.
Thanks so much for that. And there was another question from Francesca. I had a patient who had been deemed not to have ADHD as he didn't score high in hyperactivity. Do these questionnaires also cover impulsivity under the hyperactivity section? I think we covered. Yeah.
Yes, they do.
Yeah.
Yeah, absolutely. And not again, it's the core 6 out of the 9 symptoms, but the impairment, because sometimes they may be very impaired and just barely have the 6 of the inattentive symptoms, and that could be they don't need to score hyperactive impulsivity as long as there's 6 out of 9 of the inattentive symptoms and the impairment in at least 2 areas of life. Onset before 12, all this, onset before 12, not the presence of a mental illness, that diagnosis can be effective because girls or women do not have hyperkinetic symptoms as much as men. So that's why it's careful, to make that distinction that it can still be diagnosed without hyperkinetic symptoms.
That's a very important distinction to keep in mind, yeah. I had a question myself. Sometimes I do, when I talk to patients, my own patients about ADHD, I talk about how the prevalence is reasonably high, 4%, 5%, and I see it as maybe an evolutionary kind of adaptation of some sort, and I try to kind of encourage them that they will still do well in life. So I just conceptualize it as whether it's a natural selection for when in crisis they function a bit better, because I have heard 1 or 2 patients say that they work really well in a fast-paced environment. Is there any neurobiology kind of behind that kind of conceptualization, or am I just making something up completely?
No, I think the neurobiology is that children, remember we talked about the gray matter thinness in the planning executive, but in the mortal, there's found to be more thicker gray matter cortex in the mortal. So, they might also be, but again, that's a temporal relationship. Don't know whether it's because they're hyperkinetic and therefore thicker, but, more brave and enthusiastic, try new things, adventurous, the explorers.
Okay, great. Actually, I might use that a little bit more on that creative and explorer side to sell that.
And physically very able.
Yeah,
well,
yeah.
you can run some of my ADHD patients, they're athletes because, channel healthily all their energies. They say I run marathons and I love it, and they become healthy and healthier than me right now.
Thanks, Dr. Lan. Well, if we've got no more questions, I think it's the part of the evening where we do the reviewing performance questions. And I might get Nazia to share that slide and the link in the chat. This is so that we can get our reviewing performance hours, as we all need our CPD hours. Nazia's shared a QR code. If you're on your phone, point your phone at the QR code and it will bring you to the online survey that allows you to kind of reflect and review what you've learned today. Don't forget to put in your member number, your CPD member number if you're a RACGP CPD member. And if you can't use a QR code function, look into the chat box now. There is a Snap form link and you can click on the Snap form link. This just forms part of the evidence that we can collect on your behalf. So if you ever get audited, we've got some evidence that you've completed this reviewing performance questions and reflected on the topic that we've covered this evening with Dr. Lan. Whilst we're doing that, any final questions? Well, if there's no final questions, I might give everyone a little bit of a, maybe a 10 to 15 minute break initially, and then we'll come back. Is that enough time, Nazia?
Yes, Jay, that should be fine. I think 10 minutes.
10 minutes? Yeah, let's do a 10-minute break whilst everyone's filling in the questionnaire. And I'd just like to thank Dr. Lan for spending time this evening talking to us about a really topical subject. I'm sure that we've got, each of us have a lot of patients talking to us about ADHD. I certainly do. So I'm really thankful that we've had this talk this evening.
and I'm very humbled by the presence of my colleagues too. Just remember my only takeaway message: go to AADPA and get your free copy of the download. Thank you, everybody. I appreciate this.
Thanks, Dr. Lan.
Thank you, Dr. Lan.
All right, so everyone, there was a question, a practical question, no RSVGP number, no problems. You can still fill it in. I don't believe it's a mandatory field, but even if it is, just put 0000000, and it will go through. It can just form part of the evidence if you ever get audited for CPD hours, whichever field you're in and whichever college or non-college, as long as you're APRA registered. And if you need to prove your CPD hours, this will be able to form part of the evidence, only if you ever get audited. All right, so I'll give everyone a 10-minute break and then we'll restart at 7:15. Hi everyone. Hope you all had a quick break. I know some of you it might be dinner time for you, so I hope it was a lovely dinner, or maybe you're still cooking. But I had a little bit of a snack to keep me going, and then a late dinner for me. So before we begin, just a quick plug about Telecare's newest product, which we're very excited about. It's called RxPad. It's Australia's first true standalone cloud-based and mobile-friendly e-script solution. So I know that most of you, like myself in my own practice, probably already do have electronic prescribing, but for those prescribers who are struggling without electronic prescribing, would highly encourage you to check it out. I'll paste a YouTube link to show you a quick demo of what the RxPad software does. But if you've got any other colleagues of yours who are interested as well, please feel free to direct them to rxpad.com.au. But let's get on to the next session. I'm really excited to introduce Harsha, who's one of our psychologists. Now, sorry, Harsha, I will bring up your biography in one moment. I had it available before, but I've lost it. So one second. So Harsha is a highly experienced psychologist. Harsha holds a postgraduate diploma in clinical counselling and a Master's of Arts in psychology, with over a decade of cross-national experience in the field of mental health. And Harsha has been actively contributing as a psychologist since 2008 and providing psychological care since September 2014. She's also had extensive experience in community health settings, including organisations such as EACH and Eastern Melbourne PHN. In this session today, Harsha will be talking and presenting to us about acceptance commitment therapy, an approach that focuses on living mindfully and meaningfully. Through an engaging presentation today, you will discover some powerful strategies to enhance mental well-being and navigate life's challenges with resilience. Thanks so much for joining us tonight, Harsha. I'm really excited to learn about ACT. I've heard a lot about it. Well, I've heard a little about it, and I would like to hear a lot about it. Thanks, Harsha.
Thank you so much for your very kind introduction. I don't think I deserve that much of a introduction, but thank you. So I'm just going to share my screen with you. That way we don't have to get Ray to do this for us. Okay, so like Ray has already told us, we are going to talk about acceptance and commitment therapy, which I like to call the principles of which help us to live mindfully and meaningfully. So this is something of an overview of what we are planning to cover today. So hopefully we get time. So I have to pardon me if I'm just rushing through because I've got a lot of things to cover. So those are some of the learning outcomes. What are the limits for today's session is we will focus on practical tools and techniques that you can use even in your own life. That will help you to deal with just life in general, not just symptoms or difficulties like anxiety or depression, but just life in general. So this is applicable for every one of us as practitioners as well. So I'll try to focus on strategies rather than case conceptualization. We won't have time to go into a lot of empirical evidence and things like that today. Okay, so I just want to acknowledge that I don't consider myself an ACT expert, just an ACT lover. So all of the presentation and everything, the resources I've got is just through my online, just through my own research rather than, and also practice with clients. And ACT may not work for everyone because, as you know, no therapy actually works for everyone. And also that different practitioners are attracted to different models based on their personality, and also clients are attracted to different models as well. What are the two basic aims of ACT? To create a rich, full and meaningful life and be psychologically flexible. So in order to create a richful and meaningful life, we might have to allow ourselves to experience a full range of emotions. And that's where, that's how it's connected to the second part as well, to be psychologically flexible, to experience distress. Sometimes we might have to experience distress. So it's not a model where we try to get rid of distress, but teach you strategies on how to actually sit with distress in a different way. And creating a meaningful life also involves like looking at your values. So exploring values with the client is also a very big part of ACT therapy. Okay, sorry, I have to do this. What are some of the risks involved? ACT is not one of those therapies where we just talk about our problems. And it is hard. It is hard work and involves significant experiencing significant distress. And I think we have to move away from some of those talk therapies that we used to have in the in our traditional psychotherapy model anyway, because of the Medicare requirements. It's more skill based, and you have to train your clients, give them some skills to practice, and also to report back with progress, what kind of progress they are making. It's important that you give them training and things you can measure, like how you can measure progress. ACT is hard work, like I said, and it involves experiencing significant distress, and therefore it requires commitment, like any therapy. And it's not that we send people back, like if a client is not ready to change, it's not that we just send them away and say, okay, we can't work with you, but we may have to create that insight for the client that what is their readiness to change, to look at their own readiness to change. So what are the clients and therapist roles in this model? Therapists and clients have their own set of problems. They are both climbing their own mountain, which means they are both have their own struggles to deal with. It's not like the therapist has reached the top. It's not that the therapist is having a rest on the mountain. But because the client and the therapist are on different mountains, they can, the therapist has a clear view of the client's obstacles, and therefore the therapist can point out some alternative routes around the obstacles. So it's not like going to an expert for a session. It's more collaborative. What are the operating principles? Acceptance focused and whole life focused. It's not focused on very specific problems. Problems are not ignored, but they are looked in a broader context of what is the ultimate life that you want to live, and what is it that you want to stand for in the big picture of life. And therefore, we try not to use labels in ACT, because as soon as you use labels and as soon as we call something a symptom, you try to struggle with it, and therefore it goes against the principle of acceptance. So we try and transform our relationship with thoughts and feelings so that we no longer perceive them as a symptom. And although this is uncomfortable, our feelings and thoughts are harmless and transient. So we try to help our clients understand that they can't really harm you, even though it seems quite distressing. There's another important concept, principle in ACT that we need to understand. It's called self as context. So we have to help the clients understand that you have an identity that is different from your thoughts and your feelings, your body and mind, because you can actually observe your thoughts, feelings, and sensations. And self as context also means that it is a locus. Yourself is a locus from which a person's experience unfolds. It is also the observing self, or the core you, and also perspective taking. This is something this is a chessboard metaphor that helps us to understand self as context. We can watch this video later on in the end. If we have time, we'll come back to this. But basically, Russ Harris talks about how our thoughts, our positive thoughts and negative thoughts, sometimes there is kind of a conflict going on in our mind. But if we imagine that we are actually the chessboard, we become like the context on which this is happening. So we don't have to directly get involved in the battle, but we can just watch what's happening in our mind without feeling the need to get involved in it. So in order to talk about acceptance, we have to first talk about why is control a problem or why is avoidance a problem. Before we introduce the concept of willingness or acceptance, we have to help them understand why this is a problem. So I might share one of the videos with you. So I'll just pause here. And then I'll play the video for you.
Thank you, Harsha.
So just let me know if you can hear.
Absolutely. Yeah, so we can see the screen and I'll let you know about the volume. Can't hear anything yet.
It often seems
Yes, we can hear it.
got a struggle switch at the back of our mind. And as soon as an uncomfortable emotion, a painful feeling.
Can you check if other people also can hear? And we can just.
Sure, absolutely.
I'll just play it and then we can keep if on the chat if people can let us know.
We're getting thumbs up.
It's like the struggle switch goes on and we start to struggle with it. So let's suppose anxiety shows up, very common, painful emotion that we all get to experience. Anxiety shows up, the struggle switch goes on. Oh, here's anxiety. I don't like anxiety. I want to get rid of my anxiety. Now I've got anxiety about my anxiety. So it's getting bigger. With the struggle switch on, I now get, oh, my anxiety is getting bigger. How do I get rid of my anxiety? Now I've got even more anxiety. With the struggle switch on, I may then get angry about my anxiety. Why does this anxiety keep showing up? I hate this anxiety. Then I might even start to feel sad about my anger. Oh, is this my life? Oh, and then I may start to feel guilty about my sadness about my anger. Oh, how pathetic am I when there's starving kids in Africa? So with my struggle switch on, my emotions get amplified. I've now got guilt about my sadness, about my anger, about my anxiety, And that kind of amplification of emotions gives them more impact and influence over my life and often gets me bogged down or pulls me into self-defeating behaviors. Now, what happens if I can switch off the struggle switch? With the struggle switch off, anxiety shows up. And it's not that I like it or want it or approve of it. It's just, I'm not going to struggle with it. I'm not going to invest my time, energy, and effort in struggling with this anxiety. Instead, I'm going to invest it in doing meaningful, life-enhancing activities, such as spending quality time with my friends and family or playing with my kids. Now, with the struggle switch off, the anxiety is free to move. It may get higher, it may get lower, it may move quickly, it may move slowly, but the point is it's free to move. It doesn't get amplified by all of these other emotions, which make it kind of bigger and stickier and make it hang around for a lot longer. So there's no such thing as a life without anxiety. It shows up for all of us. But when anxiety shows up and the struggle switch is off, it's so much easier to live with than when the struggle switch is on.
Okay, hopefully you all went okay with that video. Now let me go back to the presentation, just bear with me.
What we might do is launch some poll questions, actually. I'll launch some poll questions from the first 3 polls whilst we're reloading the...
Thank you.
Yeah. So first poll question, what are the 2 basic aims of ACT? Now, apologies, I think we've accidentally said it, so you got only 1 correct answer. So hopefully we'll get 50-50% on the correct answers. So apologies, you can only select to answer, even though the question is what are the 2 basic aims. But just choose what you think is your favorite then. We've got a quarter of people responded. We'll just give another 15 seconds. Hopefully we can reach over 50%. Again, we've only got one option, unfortunately, even though it's asking for 2 basic aims, but feel free to answer as you wish. All right. Okay. I'll end the poll there and share the results. So Harsha, can you see the results?
Yeah, that's good to learn and apply skills. It's not exactly maybe that's the only option that's there.
Unfortunately, well, we've accidentally stuffed that up. Unfortunately,
yeah, two basic aims one was create a rich and full and meaningful life. The second one was being flexible psychologically. Yeah, so to experience distress is part of it. So we'll give it to them. That's all
yeah,
right.
yeah. So I think you mentioned to experience distress. That's right, and be psychologically flexible. So apologies that that was a little bit
Difficult.
Technical difficulties. So the second question, which I am about to launch as well.
Is that already covered?
So I'm just going to launch the second question.
Yeah.
In ACT, what is the role of the therapist and the client?
Yeah.
So there's a few different options. A, the therapist is responsible for solving the client's problems. B, the therapist and client have separate roles and responsibilities. C, the therapist has already reached the top and can guide the client. And D, the therapist and client are both on their own mountains, with the therapist providing guidance. So we've got about half of the participants having answered. I'll just give it a little bit more time. And I'll end it in 5 seconds. All right, there we go. So I think most of the participants got the correct answer, which is, I'll let you talk through that, Harsha.
D is the right answer, but I can't actually see the result.
Oh, sorry. It says it's showing, but
Can you now?
Now I can. Yeah.
Okay.
Yeah, great.
Okay. So can we go ahead?
Yep. Yeah, we can go ahead. Yes. All right. I'll pop the polls down. Yep.
Can you see the presentation now?
Yes.
It's not letting. I'm gonna have to stop share again, I think. Okay. It's not letting me move ahead. Okay. So, like I said, before we talk about acceptance and willingness, we need to help our clients understand what's the problem of avoidance. So you can ask them different questions about how they have done this so far and how they still struggle. So, for example, what are the different ways you have tried to get rid of unwanted feelings and thoughts, and how did you go with that? Did you succeed in permanently getting rid of them? So another easy thing you can ask them is forget what happened this morning, and or something like don't think about your favorite ice cream, to help them realize that actually makes them think about those things even more.
Sorry, Harsha, for interrupting you. Could you make your mic a little clearer? We may not be able to, we are unable to hear you properly. Or probably speak a little louder or closer to the mic. It's very far or very low, unfortunately. Sorry about that.
That's all right. Can you hear me?
We can hear you, but it's a little too less.
Okay, okay.
Yeah.
I was talking a bit softly. Can you hear me now?
Yes, it's better.
Is that
Thank
clear?
you. Yes.
Yeah, so before we talk about acceptance, we need to talk about why avoidance is a problem. And so these are the different questions you can, ask your clients or patients. For example, you might say, don't think about your favorite ice cream. And the more we say that, more we say, stop thinking about this, the more we think about that. So that's just a natural, normal human response. So therefore, we help them understand why avoidance is a problem before we talk about acceptance and willingness. Is that clear now?
Yes, still less, but yes.
Okay. Willingness, what is the concept of willingness? Willingness is being able to allowing yourself to experience what you're feeling, allowing yourself to be where you're at, even if it is uncomfortable or painful. Dropping your resistance to distress that is already there and that will likely come and go. Easing into it and freeing up the energy you were using to fight it to start doing what matters to you. Just feel free to stop, ask questions on the chat, and I think Nazia is keeping an eye out on there.
Yes, thank you.
Willingness, for this one, we will actually watch, hopefully we can watch one of these videos. Let me see that.
All right. Meanwhile, if anyone has any questions for Harsha regarding ACT, please feel free to just put it on Q&A section and she'll be happy to answer live. We'll unmute you if you have any concerns. Thank you.
Just let me know if you can hear it.
Have you ever
Yes.
felt
Yes, we
lost,
can. Yeah.
adrift, not really going anywhere in your life, weighed down by difficult thoughts, feelings, and emotions, struggling with depressing thoughts about not being good enough, anxious thoughts about all the things that are going to go wrong in the future, regrets, worries, painful emotions like sadness, anger, guilt, shame? Have you ever felt that way? It's a bit like this. It's a bit like all those painful thoughts and feelings are monsters. The depression monster, the anxiety monster, the anger monster. And you are adrift out at sea in a boat. And the monsters are beneath the deck. And they've made a deal with you. They've made a deal that as long as you keep the boat drifting aimlessly out at sea, not going anywhere, they'll stay beneath the deck of the boat so you don't have to see them. But the problem is, you're missing out on life. You want to head towards the shore. There's all these adventures there, all these things you want to do, all these important life goals. And so you put your hands on the tiller and you start heading towards the shore, pursuing your values towards important life goals. And the moment you do that, these monsters come rushing up from beneath the deck. Your anger, your anxiety, your sadness, your not good enough stories, all of those thoughts about how you've screwed up and how hopeless your life is and so forth. And they gather around you and they start screaming and shouting at you, which is terrifying. So what are you supposed to do? Now, if you put your hands on the tiller and head back out to sea, the monsters will disappear beneath the boat again. So there'll be a sense of relief. But now you're drifting aimlessly out at sea. You're missing out on life. So what do you need to do? What you need to do is put your hands on the tiller and keep heading towards the shore. The monsters will roar and bellow and shout and scream, but they have no power to physically harm you. It's impossible. They cannot physically harm you in any way. Your emotions, thoughts, and feelings can't physically hurt you. All of their power lies in intimidation, If you believe what they tell you they're going to do, they tell you they're going to rip you to shreds, they tell you the boat's going to smash, they tell you your life is over, they tell you that you're a loser and you're hopeless. And if you buy into that stuff, then they've got lots of power. But if you don't buy into all of their threats and intimidations and stories, they lose their power. So keep your hands on the tiller, sailing towards the shore, pursuing your values towards your life goal. And you let all of those difficult thoughts, feelings, and emotions gather around you doing their monster stuff. And interesting things start to happen. You start to get a look at these thoughts and feelings in broad daylight. You start to see that these monsters are nowhere near as big as you thought they were. They are nowhere near as scary as you thought they were. They're still ugly. They don't turn into cute, pink, floppy little bunny rabbits. They're still ugly, but they're no longer scary. They lose their power. As they lose their power, some of them disappear. Some of them hang around, and some new ones appear. You get new monsters saying, you know, when you get to shore, there'll be other monsters ready to eat you. You'll fail, you'll screw it up, your boat will smash on the rocks. And you let all of those monsters do their stuff as you keep your hands on the tiller, sailing towards the shore, pursuing your values towards important life goals, and you let the monsters do their stuff. And
yeah, I think we got the gist of it, so we better stop there. Yeah, so that's let me go back to, that's what we need to help our clients understand. Like unless we are willing to experience distress, it's going to be hard to keep pursuing our values. So that's what's most important. So willingness is an important concept that we have to teach them. So in order to increase your psychological flexibility, which is the main aim of ACT, there are 3 different things that we need to do. One is open up. Second one is be present. The third one is do what matters. So this is called the ACT triflex. So I'll repeat that again. In order to be more flexible psychologically, we need to open up, be present, and do what matters. So what are these 3 things actually? Opening up, what does that actually look like? Opening up is being able to separate, unhook, or detach from thoughts and feelings, make room for them and allow them to flow freely instead of just being fused with them or just being hooked on to them. Techniques to open up, there's a technique called expansion, which is where we look at emotions mainly. And the second type of technique is called diffusion, where we try to unhook from our thoughts. So what does expansion look like? We get our clients to bring their awareness, so observe what they're feeling in their body, what kind of sensations they're feeling.
Harsha,
yeah.
sorry to interrupt. I was wondering, could you speak closer to the microphone? We've got some, yeah, maybe that might help a little.
I don't know whether there was it better in the beginning?
Yeah, that's better with it being closer. Yes.
Okay. Was it better when I started? I don't know whether because I changed something with the view or something.
It's certainly better now. So yeah, I think keep doing what you're doing. Yep.
Okay. So in order to open up, there are 2 kinds of techniques. One is expansion. The second is diffusion. Expansion is mainly related to emotions, and diffusion is mainly related to thoughts. Expansion, this is the technique, but there is a kind of instruction sheet that if you want, you can find it online. I will show you where to get that. But basically, these are the 4 steps of expansion: observing, breathing, expanding, and allowing yourself to feel whatever you feel. Some people find it helpful to silently say like, I don't like this feeling, but I'm going to allow myself to feel this. I have room for it. and it's unpleasant, but I can accept it. So doing this, it helps you to not struggle with it, because struggling with it, like we saw in that struggle switch video, only makes our feelings worse when you struggle with something. So that's why it's important that you make room for these feelings, because making room for these feelings just means you're going to accept and be willing to have them there, because whether you like it or not, it's already there. They are already there. Diffusion. Why do we diffuse from our thoughts? What are thoughts basically? Thoughts are basically sounds, words, or stories, bits of language passing through our heads, but we give them more power than they actually have. Thoughts may or may not be true, and therefore we don't need to believe them. Thoughts are not orders, so we don't have to obey them. Thoughts may or may not be important. We pay attention only if they are helpful. Thoughts may or may not be wise. So how do we decide whether a thought is helpful or unhelpful? By asking these kinds of questions. What would I get for buying into the story? Does this thought help me to take effective action? Does it help me to be the person I want to be? Does it help me to connect with my values? So there are some diffusion techniques that we can use. There are metaphors you can use. So there's the sushi train, the leaves on a stream. There's also singing your negative thoughts that can also help to diffuse, basically to step back and observe your thoughts. So I want to show you one of these videos. We are not going to have time, maybe two of them actually. Let me try and share that with you.
Harsha, is it okay if we share the slides at the end of the presentation with the attendees?
With the attendees, I am not sure. So this webinar is going to be recorded, right? So can they have access to the webinar?
Yes, we'll make the webinar available, definitely.
Yeah, the recording. I prefer if the recording, if they see the slides on the recording rather than me giving the slides, just because everything is available. I will tell them where exactly they can find these resources. So everything is already available. So there might be some issues if we share and someone else's property or something.
Okay, yeah, that'll be great. That'll be great. Thanks, Harsha. Yeah.
That's all right.
This activity is called Leaves on a Stream, and it's an exercise from
Can you hear the video?
Yes.
acceptance and commitment therapy. This exercise helps you develop the ability to separate yourself from your thoughts, noticing them and observing them instead of becoming sucked into them. You are not your thoughts. You have the ability to observe your thoughts. This is called cognitive diffusion, which is just a big word for saying getting unstuck from your thoughts. So let's begin our practice. Sit in a comfortable position and either close your eyes or rest them gently on a fixed spot in the room. Take a breath and notice what it feels like to breathe. Allow yourself to become aware of the present moment. Notice what the chair feels like pressing into your legs. Notice your breath. Notice the sounds around you. Imagine yourself sitting beside a gently flowing stream with leaves floating along the surface of the water. Notice what it sounds like, what it looks like, what it smells like. During this exercise, thoughts are going to pop into and out of your head. With the first thought that comes in, imagine placing that thought on a leaf and allow that leaf to float on by. With each thought that comes, whether the thought is happy or sad, enjoyable or uncomfortable, place that thought on a leaf and let that leaf float down the stream.
Okay, so that's basically the technique. Sorry to interrupt you, a very relaxing moment there. But we just have to keep pushing through the slides and getting through the slides. Sorry. So that's on here. So you can use leaves. Can you still hear me, Nazia?
Yes, we can, Harsha.
Yeah, so we can use different metaphors, just like the leaves on a string. We can also use sushi train. There's also another technique called thanking your mind. Basically, whatever your mind says to you, even though it's nasty or provocative, you just say, oh, thank you, mind. It's just like if you have like a person in your life who always gives you a lot of advice and feedback, in order to disarm them, you might say, oh, thank you for your feedback. Just like that, to just to keep moving on. In the same way, we deal with our mind whenever it becomes too much, like giving you too much advice or saying, oh, you're a loser, or whatever your mind's telling you. Say, oh, thank you, mind, for your feedback. So that's another way to diffuse. So your clients, some of your clients may not like certain techniques or metaphors, so they can choose their own metaphors, or they can choose their own ways to diffuse, whatever works for them. So you can also use like, saying your thoughts out loud in a cartoon character's voice, a funny voice or something like that. So whatever works for your client. So not all metaphors are going to resonate with your client. Oh, get back to that story again. Not sharing the proper one. Yeah. Okay. So metaphors, like I said, you can use any different, any metaphor that your clients like to use, clouds, waves, whatever they want to use, or they can sing their thoughts, or they can say their thoughts multiple times, or repeat their thoughts loudly, so that they can, just any way that they like to diffuse. So there's no specific rule that this is the way you have to diffuse. Be present is basically mindfulness, which is engaging fully. So remember the act, try, flex. One is be open up. The second one is be present. The third one is do what matters. So we are up to the second one, which is be present. So that's basically being able to focus on what you're doing in engaging in it fully. And also it helps you to empathize with somebody, because you learn how to listen without judgment, just be present with people as well. So mindfulness is basically connecting with your present moment using sense organs. We will come back to this video if we have time at the end of the session today. So you can use mindfulness in your morning routine, just using your sense organs to focus on the activity. So it can be like when you're in the shower, what kind of things you can notice, like the sound of water, temperature, smell, sight, all of these things. Mindfulness of domestic chores, the same thing. You can pick a chore that you don't like or you distract yourself from, same thing. You can, focus on the color, the shape, whatever you want to focus on using your sense organs. Doing what matters is about being clear about and connected with your values and setting goals based on your values, because when you set goals based on your values, it gives you deep motivation to keep doing them. And also the third thing is take and sustain value-guided action. So you need to sustain those activities. What are values? Values are things that are important to you deep down in your heart. Values stand for things that you would like your life to stand for. So we can have different ways in which we explore values with a client. We can either do it by asking them, like, if this is your last day on the planet, what do you want your life to stand for? or you can use values sorting cards. There are value cards available, and you can use, you can ask your clients to sort them according to what values are, which of them are important to them. There's another way of doing like a 80th, it's called 80th birthday celebration exercise, where you ask them to imagine that they're 80 years old. That is, if they are like 50 or something like that. You won't tell like maybe a 70-year-old, you may say like, imagine you're 100 years old or something like that. So imagine you're 100 years old, there's a birthday celebration in your honor, and you have to pick 3 people to speak, make a speech about you. And what would you like them to speak about? So try to keep the focus on positive things, not things like, oh, I regret, I should have done this. It's not that, but try to help them to focus on positives, like what would you actually like them to say, and what would you want your life to stand for. Reflect what you want to do. There are some chats coming up, Nazia, hopefully you can have a look at that.
Sure.
There's also a bullseye worksheet that you can use to assess your values, like how you're traveling the values. So hopefully I can show this to you to the link. Maybe I'll come back to that, because when I go somewhere else, it's hard to come back to this. So what is the difference between values and goals? Values involve ongoing action. It's like a direction that we keep moving in, and goals are things that we achieve along the way. So a value is something like heading west. A goal is like the river we aim to cross while traveling in that direction. And goals can be achieved or crossed off, whereas values are ongoing. So no matter how far west you go, you never reach it. For example, if you want to be a supportive partner, that is a value requiring ongoing action. If you want to get married, that's a goal. It can be achieved. So this is where we need to help our clients differentiate between values and goals, because their goals need to be based on their values for them to have a deep motivation to keep working on their goals. Goal setting, obviously, I think this is very famous, SMART goals, where S stands for specific, meaningful, adaptive, realistic, and time-bound. So meaningful, how does a goal become meaningful is when your goals are guided by your values. Okay. So let's watch this one. It's called the choice point.
For everyone who was requesting for the links to these videos, we'll be happy to share them tomorrow in the email. So Harsha has been kind enough to share all the links with us prior to this presentation. So we will definitely share that in an email. So you can keep an eye out, and we'll definitely share it with you all.
Yeah, if there are any questions also, maybe you can, even after the session, if we don't get to address all the questions, maybe Nazia can keep an eye out for more questions, and yeah, I will endeavor to answer them later, maybe.
Sure.
So just with the slides, it's just the slides. I've just pulled resources from different sources and just put them together. So it's not like something that I've created. That's why that's the only problem with the slides, sharing the slides. The choice point, hopefully you can hear this.
All day long.
Just let me know if you can hear it.
Yes, it's audible.
We're always doing something, even if it's just sleeping, we're always doing something. And we can broadly classify what humans do into 2 large groups of behavior. We can talk about towards moves. We're doing things where we're acting in line with our values, behaving like the sort of person we want to be, acting effectively, doing things that help to make life better. Or we're doing away moves, moving away from our values, behaving unlike the person we want to be, acting ineffectively, doing things that don't improve life or make it worse. And what we're aiming to do in this course is give you a lot more choice so that you can choose to do more towards moves. The more you choose towards moves, the richer, fuller, and more meaningful your life is likely to become. The more effective you are likely to become at creating the sort of life and achieving the goals you want to achieve. Now, what happens is that in a challenging situation, difficult thoughts and feelings show up for us. And when we get hooked by those difficult thoughts and feelings, we tend to start doing away moves. Difficult thoughts and feelings might include depression, anxiety, stress, pain, suffering, fear, anger, guilt, really, thoughts about not being good enough, thoughts about failing or screwing it up, a whole range of difficult thoughts, feelings, emotions, memories, urges, sensations. When we get hooked by this stuff, typically our default setting is we get pulled away from our values and we start acting ineffectively. And so what I'm aiming to do in this course is give you a lot more choice so that when you're in those challenging situations, whether it's relationship issues, health issues, financial issues, work issues, whatever those challenges are for you, when those difficult thoughts and feelings are showing up for you, I want you to be able to unhook yourself from those thoughts and feelings and make a choice, a wise choice, a choice that you decide as wise. I want you to have the freedom to choose towards moves if that's what you want to do.
Yeah, so basically, I think that the course he's talking about is found there on www.amlearningapp.com. So you can try that, but I will also give you other websites as well in the end. Yeah, so is there any question at this point? Do you have any questions, or do you want to do the polls again at this point?
Yes, I can launch a few polls to keep it interactive. So can everyone see the question? So question 3 is, which of the following best describes the operating principles of ACT? So the options are focusing on specific problems and labels, B, ignoring private experiences and symptoms, C, acceptance focused and whole life focused, and D, talking about thoughts and feelings in isolation. I'll give another 15 seconds. All right. So I've got just over 60% respondents. I'm going to close it off now. I've just shared the results. So overwhelming majority, 94% said acceptance focused and whole life focused, which is the correct answer. Fantastic. And I'll just launch the 4th question. So poll question 4, what is the purpose of diffusion techniques in ACT? A, to eliminate unwanted thoughts and feelings. B, to label thoughts as symptoms for further analysis. C, to separate from unhelpful thoughts and create distance. D, to control and obey thoughts. So we've got just over 50% now, a little bit longer. Okay. Great, 5 more seconds. All right. So the majority said C, to separate from unhelpful thoughts and create distance, which is the correct answer. There was a significant portion that said to eliminate unwanted thoughts and feelings. Whether you wanted to expand on that?
Yeah, so we don't want to eliminate unwanted thoughts and feelings, because when you try to do that, it only gets worse. That's what I was explaining in the beginning. Like if I say, forget what happened this morning, your natural reaction is to go back and, oh, what actually happened this morning? You're trying to think. Or if I say, stop thinking about the pink elephant, and you go, oh, what does it actually look like, a pink elephant? So that's our natural response. And therefore, in that struggle switch video also, they said, like, when you struggle with your feelings, they get worse. So when you say stop thinking about something, you think about it even more. So it's not possible to eliminate unwanted thoughts and feelings, even if you want to do that. That's why we are talking about willingness, letting your thoughts flow freely. That's our aim in that.
Yeah, thanks, Harsh. Did you want me to launch any more polls, or we keep going?
We just watched the last, the summary video, and then I want to, you can do some more polls, and I also want to go back to some more videos.
Okay, all right.
This is just a summary of ACT. Just let me know if you can hear the
In
video.
this video, I'm going to show you the one simple diagram that incorporates all of the 6 common core processes in ACT to help you better chase your values, even when your yucky pain monster shows up. Look at that thing.
Can you hear?
Yes, we can all
Yes.
hear. Yeah.
Pretty creepy. All right, let's roll that intro and get this thing started, because this is awesome. Not easy way altogether in one diagram. Now, I know that sounds like a really lofty goal, like, yeah, you can do all of ACT in one. So the matrix is a really simple diagram that you can actually use all of the 6 common core processes in acceptance and commitment therapy altogether in one diagram. Now, I know that sounds like a really lofty goal, like, yeah, you can do all of ACT in one diagram, but really it's all here in this one diagram. It's really cool. And I'm not saying that we're going to be reductionist about ACT and that it's simply just this one straightforward thing and that's the whole intervention. No way, there's a lot more to it. But this diagram is a easy way, I should say that differently. This diagram is a simple, but not easy way of delivering ACT. And the whole idea behind this is that it gives you a springboard to do a lot of different interesting work in acceptance and commitment therapy. Let's get started with the ACT matrix. I'm actually going to show you a little bit of an adaptation that my colleague Jessica Borshak and I call the life map. We've used this in our own books, publications, as well as in pilot studies that we've run. It's really simple. You're going to start with a horizontal line. And that's it for the art portion of the activity. Horizontal line, arrowheads on either side. Now, the reason why we throw up arrowheads is because we want to describe 2 different directions that you can move in your life. The first direction is where you chase. Who and what matters most to you in your life. So follow along at home, like actually think about who and what matters most to you in your life. The things, the qualities that you want your life to be about, that you want to chase, the things that are delicious to you, you have an appetite for, the qualities that you want your life to be about. On the opposite side of the spectrum, we're going to talk about the difficult things that show up inside of you, the painful thoughts, feelings, sensations, or memories that actually get in the way of you chasing who and what matters most to you. These are the things that you would want to escape. And what I mean by escape are the difficult thoughts, feelings, sensations, and memories that actually get in the way of you chasing who and what matters most to you. So what are the things in your life that you might want to escape? It could be chronic negative thinking, painful sensations that show up in your body, ruminating about, what could be happening, or painful thoughts about things that have happened in the past. Any difficult stuff that shows up for you that actually gets in the way, things that you would want to escape, avoid, control. This is what we look to track over here. Rather than writing down a smattering of random examples, I'm just going to draw my yucky feelings monster over here.
So the reason why they are on opposite poles, opposite sides, the escaping and chasing, is because when you're escaping or avoiding your feelings and distress, you can't at the same time chase your values and be mindful about your values. That's why they are on opposite poles, right?
We want to track, what do we actually do when we attempt to escape all of this yucky stuff in our lives? When the difficult, painful thoughts, feelings, sensations, or memories show up for you, how do you try to escape it? What do you do? And at first blush, your escape behaviors might not actually be problematic. I mean, remember, if a building is burning or there's a giant fire, you might want to run away from it. Different contexts call for different behaviors. What we want to focus on is not pathologizing ourselves for simply trying to escape the painful things that show up in our lives, but really pay attention. Like, what do you do when your painful thoughts, feelings, sensations, and memories show up for you? How do you try to escape it? What do you do to control or to avoid it? That's what we really want to pay attention to. Because remember, this diagram is all about non-judgmentally, let's just look at how our behavior works in all these different situations. Now that we have the behaviors that we do to try and escape our pain, now we want to focus on what are the behaviors that we could be doing or that we're already doing that help us chase who and what matters most to us. Engage with the life that's delicious and important to you. So there we have it. On one side of the spectrum, chasing who and what matters most to us. What does that feel like for you? In my life, when I'm engaging in behaviors that help me chase the type of life that's important to me, when I'm walking my dog, chilling at home and watching Netflix and just like enjoying some yummy food, that feels satisfying to me. It feels relaxing and peaceful. I feel like I'm in my element. And when I'm escaping the painful thoughts, feelings, sensations, and memories that I don't want to have, what does that feel like for me? It feels like, well, I'm trying to run from a burning building. It feels like I'm just like escaping in the short term. So these are things like when I'm watching Netflix in order to distract myself because I'm feeling anxious about writing another chapter. Or maybe I'm worried about a friend of mine and have tried to, text him and I've tried calling him and he hasn't responded. So I'm starting to have this thought like, ooh, like maybe I did something to offend them. And what does that feel like for me? I can tell you, not very good. It actually makes me feel worse in the long term. I want you to do the exact same thing. Just take a moment here to pause and reflect. What does it feel like to chase your values? Attention, noticing. It's kind of like when you go to the mall and you look at the map at the mall, want to feel. And how's that working in any given situation that you find yourself in? You see, the core of this work, paying attention, noticing, it's kind of like when you go to the mall and you look at the map at the mall and the map has a little red dot or a little gold star and it inevitably says, you are here. That's what this diagram is all about. It's about putting you at the center of this perspective. You are here. I know that's dead simple, but remember, it's about having you pay attention to your experience on purpose. ACT is all about giving you or your clients processes to empower your life. You see, you being at the center of this perspective is about you being able to pay attention to your experience so that you're more easily able to choose what you do next. And isn't that important? That's our definition of freedom. To be free from being governed by our pain, to get out of this cycle of negative reinforcement, just constantly trying to escape what we don't want to feel by attempting to control, escape, or hide from this stuff. Avoid it, and instead, paying attention. Let's be purposeful in actually looking at what our experience is about, and then you get to choose what you do next. And hear me when I say, not all behaviors that are about chasing your values are inherently good. Like, sometimes it's really important to run away from something hazardous or dangerous. If you hear a loud crashing sound behind you and somebody screams, get out of the way, and as you turn around, you like take a breath and you're noticing a Honda Civic careening towards you at a high rate of speed, I want you to get out of the way. Like, that's important. Escaping painful stuff is actually evolutionarily essential. You need to get out of the way. You need to run away. You need to escape. This perspective is about helping you to pay attention to when attempts to escape maybe aren't working for you. Asking yourself, well, what do I actually want my life to be about? What would that look like? And clarifying that. And that can actually be a really hard question to answer for so many different people. Someone, who and what is most important to them? What we're really doing is looking for values that you get fused with. And I mean, for me, honestly, drawing my painful thoughts, feelings, sensations, and memories, my own anxiety, my own self-judgment and procrastination as a yucky feelings monster, that's pretty diffusing for me, straight up. And when we say, what do you do? How do you try to attempt to escape, avoid, and control? What we're looking for is the behaviors that we want to be a little more accepting of. Here we have our acceptance process. Experience. What does it feel like to move in this direction? What does it feel like to move in this direction? And just like take a step back, notice that you have all of these different experiences. That's self as context. You see, when you look at this perspective, you can see that you're here. This isn't who you are. This isn't who you are. These are things that you choose. This is stuff that shows up for you. But you go here at the center. That's a self with context move. So here we've got all of, that's about the present moment.
Sorry.
And paying attention to your experience, actually acknowledging what this is like, paying attention to those experiences, noticing them on purpose, that's about the present moment. So here we've got all of the 6 processes in ACT. I promised you at the beginning of this video, we were going to look at all 6 of those, right? This diagram is one easy way of doing all 6 of those complex processes. So what we could say is that the matrix is a way of doing acceptance and commitment therapy. It's a way of doing all of those processes. It's a methodology. We have our values. We have the fused content that we want to defuse from. We have our acceptance that shows up here with the difficult behaviors that we could be doing to try and escape this painful stuff. We have commitment towards who and what is most important to us. We have the self as context, observing this thing, seeing that you go here, that you are not your pain, you are not your trauma history, and you don't rigidly have to be the most amazing parent ever, the best author who's the most committed and writes 1,500 words a day, right? I mean, those might be values that you have, but you go here, you're at the center of this point of view. You're separate from all this stuff. You're the observer of it. And finally, that you can be here now in the present moment and sort all these different things. You can choose, author what you want your life to be about. You can notice all this painful stuff that shows.
Yeah, so basically, he's trying to say that we have a choice to whether to decide how much we want to diffuse, when we want to accept, and when we want to chase our values. So I think that's about it. Let me just see. Yeah, so the references, for references, you can go to actmindfully.com or the happiness-trap.com, actmindfully.com.au. So all of these videos and resources, worksheets, everything is available there. So you can either, Dr. Ray, you can either go to the polls or look at these questions if you want.
Yeah, sure. I can launch some of the polls and then we can maybe run through some of those questions as well, one by one. So I'm launching question 5. So how can mindfulness be practiced in daily routines? A, by distracting oneself from thoughts and focusing on tasks. B, by multitasking and trying to complete chores quickly. C, by focusing on the present moment and fully engaging in activities. And D, by avoiding domestic chores to reduce stress. We've got almost half of the participants having responded, so we'll just wait a little bit longer. All right, I think that's tapered off.
How are we going for time? Focusing on present.
For time, in theory, we finish at 9 is my feeling, but certainly we can finish up a bit earlier if we finish. So in terms of the poll, can you see the results?
Yeah, that's the right answer.
Yeah, great. So I wish I could do D, but unfortunately, I think not allowed. Question 6, what is the difference between values and goals in ACT? A, values involve ongoing action while goals are achieved once. B, values are specific and measurable while goals are abstract. C, values are related to thoughts and feelings while goals are external. D, values focus on solving problems while goals focus on acceptance. Yeah, we've got some responses flooding in now.
Yeah.
We just let everyone have a chance to respond.
Yeah, and also maybe we can welcome some questions from everyone who's listening.
Yeah. If anyone's got any questions, just pop it on in the chat or in the Q&A box. So feel free to ask any questions or any points that were not clear. All right, I'll end the poll now. So question 6, the values involve ongoing action while goals are achieved once. That's the correct answer. So majority did get that right. There was maybe a little bit of confusion between values and goals, given the disparate responses. But I did like your analogy that values are direction, like west, and you never reach it, as opposed to goals being like a river that you reach at some point in some stage. Yeah.
So
All right.
we could go back to the videos that I had that I was going to, or we can take questions, or we can do both at the same time.
We can do, maybe we'll do a bit of questions, get everyone interactive.
Yeah.
So we've got one question from Dr. Johnston. How can one go about becoming a practitioner of ACT?
Well, I am a psychologist who practices ACT with my clients. I've just, like I told you, I've just, did my own research online and just practiced it. But I think there are courses, Russ Harris runs courses, so you can sign up with Russ Harris. Yeah, but other than that, I'm not sure whether you need, I don't think you need a certificate or anything to practice ACT. Yeah, but I think ACT is also more like you can use ACT for your own personal life as well. So it's not something that there's clear guidelines for. Just for example, when you are an EMDR practitioner, you need certain a certificate that you've done a course and training, but for ACT, I don't think there is anything like that. So you can be an ACT practitioner if you feel confident.
Thanks, Harsha. We had a question about the difference or similarities between ACT and CBT.
Yeah. So in CBT, usually we work on your thoughts that are maladaptive and try to reframe thoughts. So they call it distortions. So there are some logical errors in thinking, and they will get you to think about, okay, how does it compare with evidence, and then to reframe thoughts. I think CBT is helpful to work with core beliefs and to understand where your thoughts come from. But ACT is more related to not debating your thoughts, but changing your perspective, like observing your thoughts rather than debating your thoughts, because some of our thoughts may actually be true, right? So some of our thoughts, for example, if your doctor says, oh, you have only 6 months to live based on your diagnosis or whatever, it might actually be true. So you can't really, reframe it or challenge it based on evidence. So ACT is more helpful in those situations where you say, okay, there's no point really debating with my mind, but is there, how is it helpful to really focus on those kind of thoughts? Is it really helpful? Does it make my life adaptive to focus on those thoughts? So that's how it's a little bit different from the CBT approach, where we try to change our thoughts to make them more balanced and make them more based on evidence. Is that clear?
Yeah, I think that's a good way of putting it. That it's whether there's evidence, and even if there is evidence, trying to debate yourself is not going to be helpful. Certainly in my own practice, I've found that the patients who are quite intellectual find that CBT doesn't work quite as well as ACT, or I've had less success with CBT based therapies with them compared to ACT. And I do wonder, what's your your feeling why that may be?
I think people, like I said before, about personality, and also sometimes people like structure. and might prefer the cognitive route because it's more structured. The ACT can get a bit abstract in the sense that sometimes metaphor, if people don't understand metaphor, sometimes I think my supervisor once told me about people who are on the spectrum, like the autism spectrum, sometimes struggle with metaphors. But in my own practice, I've found that we can use different ways. We don't have to get stuck on metaphors. We can use different ways, like in this example, like I said, about thanking your mind, or use different ways to try it. But I think it's also about trying things out and seeing, okay, I have tried this for maybe 3 to 4 times and still doesn't work for me. And then we can say, okay, that's something different. But I think both these therapies, like I said, both these models have value. Sometimes people say that CBT can get too heady in the sense that even after we challenge and reframe our thoughts, sometimes that doesn't result in a change in how we feel about situations. So there can be a disconnect between the head and the heart, or you can feel like it's just a mental activity that we are doing with the challenging rather than it translating into how we feel. But I think having said that, I feel like it takes time, like even for CBT to kind of influence and change your life behavior or feelings, it takes time. So I won't say that you should give up CBT because that's your experience. Maybe you should give yourself some time to really have that effect, like for it to really get absorbed into your feelings and your life. Does that make sense? Yeah.
Thanks, Harsha.
Also the behavior, like in CBT, they say the behavior leads to, if for example, the behavior, thoughts and feelings are connected to each other. So thoughts influence your feelings and feelings influence your behavior, and they are all influencing each other. So if we look at ACT and go, okay, if we engage in positive behaviors, CBT says that if we engage in positive behaviors, that can actually result in feeling positive as well. So if we use the mindfulness techniques where or the values, where we are just focusing on values, even though you don't feel like it, I'm just going to keep focusing on my values, even though my anxiety is saying you're going out of your comfort zone, making me anxious. I'm going to say, no, that's something I value. I will do it, pursue my values no matter how I feel. I'll keep, and I'll make room for those feelings. I think that's also a kind of chasing positive feelings, then that also automatically, slowly, gradually results in a change in how you feel as well. Does that make sense?
So there's a bit of a relationship from what you're saying.
Yeah, so we don't have to say, oh, this is exclusively CBT, but there is, that's the basic difference. Like we don't, in CBT, we challenge your thoughts and we, in ACT, we take a different perspective. We just say we're going to observe our thoughts instead of challenging our thoughts every time, because challenging our thoughts can take a lot of time and energy away from our values and being present in life.
Yeah. Thanks, Harsha. Now we've got quite a few questions. So Francesca, leading on from what you were just saying, what makes ACT more suitable than other types of therapy, or patient more suited to ACT? Is it an adjunct to CBT, somatic therapy, DBT, etc., or best to be worked as a standalone therapy?
Like I said before, I actually use some of these principles from both therapies. Like I said before about working with trauma, sometimes there is value in looking at core beliefs, beliefs that lead to your thoughts. So core beliefs are beliefs that are deep down in your heart that lead to kind of your thoughts. So basically understanding your core beliefs. Core beliefs are sometimes, like with trauma, it's like a lens that you look at the world through. So for example, if I have a yellow lens, everything I look at seems yellow. In the same way, when you go through trauma, your trauma beliefs kind of shape or influence everything you're looking at. Every situation you're looking at is going through that trauma lens. So in those situations, I think it's helpful to look at your core beliefs through a CBT model. And so I don't use it as a standalone. Sometimes I kind of use techniques from here and there and use it as appropriate. So yeah, so it's not really, I can't say that it's only appropriate for certain kinds of diagnosis, because ACT has been proven to be effective for many different diagnoses and problems, depression, anxiety, trauma, things like that. So
yeah.
yeah.
Thanks, Harsha. So Dr. Sam Daniel, what is the, asked, what is the difference between mindfulness and awareness?
Mindfulness is basically using your sense organs to fully engage in an activity. So an example would be here, they've said about using, for example, what are the 5 things you can notice, what are the 5 things you can see, what are the 5 things you can smell. So using your sense. So I think mindfulness is more focused on a particular, so it's you can use mindfulness to focus on whatever you want to be mindful about. So awareness is more, I think, general about I'm aware of my surroundings that way. So I don't know whether I'm clear in my response, but yeah.
Yeah, I think I get the gist of it.
Did you want to explain what you understood, maybe?
I think what you were saying is that mindfulness is kind of using kind of everything in your sense organs to kind of anchor yourself in the moment, in the present, whereas an awareness is just literally kind of being aware of your surroundings.
Yeah, it can be general. Awareness doesn't have to be a specific thing. That so mindfulness is a particular technique that you use to focus on certain things. So it can be like mindfulness of breathing, mindfulness of eating, or this particular technique in grounding where you use sense organs. So you say, what are the 5 things you can notice? So that's a mindfulness technique. So awareness is, for me, I feel it's a more general term rather than a specific technique in ACT. Does that make sense?
Yeah. And Eric van der List asked, do you find it difficult to get patients motivated to undergo ACT?
Yeah, there can be. That can be an issue. Like I said in the beginning, ACT requires some commitment, but more than the therapeutic model itself, I feel like there might be some misunderstanding about what therapy means, because sometimes people think, oh, I just want to talk to somebody, and that's therapy. But unfortunately, with the Medicare system and how the referrals work, we cannot just waste time talking and listening like a psychoanalytic kind of model anymore. So therefore, I think more than ACT itself, I think it might have to do with the readiness to change, or readiness to change in general, and to look at their problems, because they have, even in CBT, whether you use CBT or ACT, even in CBT, we have to, there comes a point where they have to confront their anxiety and face their fears. They have to do, if they want to progress, they can't keep avoiding their anxiety. So there might be situations like we might do like behavioral experiments where they expose themselves to their, anxiety provoking situations. So I don't think it has to do with ACT per se, but it's just maybe how ready they are to work on their issues. Yeah.
Francesca asked, in ACT therapy, is it a requirement that the therapist is also working on their own issues, on their own journey? Does this refer to a specific journey through ACT therapy?
I don't know what exactly you mean by do they need to work on it. It just means ACT is helpful for everybody. And in ACT, like I said, with the therapist client roles, we clarify that you're not coming to an expert. So don't expect me to have my life in order. Those kind of things are more about setting the expectations or setting the tone for sessions where you're saying you will need to do this hard work as well. But whether practitioners practice ACT on themselves or not, I'm not sure, because I don't know how many people actually work or use ACT, but ACT is beneficial if you use it. If I use it in my own life, I know that it has a lot of benefit for myself. So it's a good idea for practitioners to use it. Whether they actually use it or not, I'm not sure.
And Simon asked, is ACT the best treatment for ADHD, or is it effective for ADHD?
I can't say that. And like I said, like for a particular diagnosis, I won't be able to say. I just know that ACT has been proved to be effective for many diagnoses like depression, anxiety. I'm not sure about ADHD, whether there's any empirical evidence for that. But under this, if you want to look at empirical evidence, you can look at this page, website here in actmindfully.com. But yeah, I'm not sure about ADHD.
Yeah.
I have had clients with ADHD, but it's like I said, it's again comes back to not specifically to ACT, but their own ability to engage in sessions. So because ADHD can, create obstacles to be engaged in that way. So that can become an issue in general. But I do have a client that I had this morning. She's about 80 years old and has ADHD, but yeah, she has been engaging in sessions very well. Like I finished like 18 sessions with her, and she's going to have more sessions with me. So we can't put a box and go, okay, all ADHD clients, don't find that, don't find this helpful or whatever, or have difficulty. That's why I don't want to put them in a box that way, because there are individual differences as well.
Yeah. And there's individuals always have different comorbidities as well. Now, Shantala has asked, what sort of time frame do you estimate is usually required for therapy to at least to start to see or feel some results?
Yeah, so in ACT therapy, Russ Harris actually suggests that give it at least 2 to 3, give it 2 to 3 weeks. So it's, it's not helpful to just say, okay, I finished one week of this and say, okay, it doesn't work for me. At least give yourself 2 to 3 weeks to see it. But then again, like I said before, I feel like it might have to do with commitment in general rather than specifically ACT. When people say this doesn't work for me, but in the initial session, that's what we say. Like we actually tell them, no therapy works for everyone, so ACT may not work for you or work for everyone. That's what we have to say as part of the informed consent. That's what we are recommended. But deep down, I feel like it might come down to like, because even people with difficulty visualizing things, we can find other ways. So there might be certain techniques. I don't think ACT in itself, we can discard the whole model and go, oh, this doesn't work for me. Maybe there are certain techniques that we need to kind of to make tailor techniques in a way, adapt techniques in a way that becomes more makes sense to the client.
Yeah. And second last question, Nahal's asked, what is your approach to working with people to accept their feelings if they are too distressing? Are there contraindications for you to the techniques in ACT around acceptance and diffusion?
We'll have to go gentle, like especially with certain things like expansion, for example. This technique involves sitting with your distress, and sometimes people have said, oh, that's too much for me and I can't do it. So we might have to like stop that, pause it, and come back, revisit it at some other stage. Yes, when they are quite anxious, they don't even want to hear the introduction bits where we talk about we need to be willing, and so that just they are so distressed that they don't want to hear like we need to be willing and accept our feelings because that's better, because they don't want to hear that. So yeah, there are some clients who are distressed like that. So that may not be the right time. I would say that may not be the right time for us to introduce that. Maybe we should go gently with something else that they would like to use and then come back to it. Yeah, so we might maybe try mindfulness instead, mindfulness of breathing, or mindfulness of like you can use mindfulness of chores, domestic chores, whatever that helps them be present. So I'm not saying that we completely take this off the table, but we can talk about other, we can bring them to that acceptance slowly. So because mindfulness may not necessarily involve like sitting with distress so mindfulness, you can focus on different things if you want to be focusing on, like, for example, a chore or something. That makes sense?
Yeah, that does. So it's that concept that sometimes they're not ready, or and it's about treating the more acute symptoms first and the acute distress first. So a bit of a trauma-informed approach. Yeah. And then finally, Francesca's asked, this might be a bit of a silly question, but is there a risk for patients falling into accepting or trying to accept their thoughts and beliefs without challenging the realities of these thoughts and beliefs? Or is that assumed knowledge on the practitioner's behalf that they would need to guide the acceptance appropriately? Is it more of acceptance of feelings and then changing perception of these feelings and situations?
I don't believe there are any silly questions, but I have to read your question again, sorry, to understand clearly. Let me have So is there a risk of for patients falling into accepting or trying to accept their thoughts and beliefs without challenging the realities of these thoughts and beliefs? Or is that assumed knowledge on the practitioner that they would need to guide the acceptance appropriately? So just because we have, like I said initially, thoughts are basically sets of words or images passing through your head. They only have power as much as you give them. So they will have power to influence or control you only if you give them that power. So even if I have a silly thought, like for example, I have like a chest pain and I say, oh, I have a heart attack. Maybe that's not based on facts. But if I have a thought like that, we have to teach them to defuse from that thought rather than say, oh, I'm not having a heart attack because it's not. So in this approach, in cognitive behavior therapy, obviously we say, okay, look at the past evidence and say whether this is based on evidence. But in this ACT approach, what we say is that we don't need to challenge all our thoughts and beliefs, even if they are true. Does that make sense?
Yeah.
Because challenging our beliefs might take up a lot of our time, just caught up in our mind, rather than living our life, based on our values, and it takes us away from our values. That's what the problem is. Did I answer your question, Francesca? Did I understand your question properly?
Francesca says, yes, thanks. So that was good. Thanks, Harsha. Any final questions this evening? All right. Well, thanks, Harsha. Thanks so much for running through ACT. I think it's not something that's previously well taught, at least when I went through medical school or through GP training. So I'm really glad to kind of learn a new technique that's going to guide me in guiding my patients in selecting different types of therapy techniques. So thank you very much for running through that. And it sounds very well, useful. Might try and practice some of these techniques in my own life.
And also, I was just thinking maybe some of the psychology friends might think, oh, why is she oversharing all this information? We will run out of jobs, or lose jobs, psychologists. And if they do, I feel like my work is done, today.
Yeah. I don't think you'll be short of work at the moment. There's a lot of work.
No, I just think that the session would, I would say the session was successful if you think that you can practice it, and confidently. Yeah.
Thanks, Harsha. So we're going to put up the QR code for the reviewing performance questions. But if you've got any burning questions that you didn't get answered tonight, or you're watching this recording later on, just send us an email and we can pass that on as well. So thank you so much, everyone, for joining us this evening. Thanks, Harsha, for taking the time out and attending the full session tonight as well. So we'll just put up the QR code, and Nazia's got the a snap form link there in the chat. So if everyone just clicks on that link, it'll take them to the post-session reflection and reviewing performance questions. Thanks, Harsha.
Thank you.
I have shared up the QR code. Is it visible?
Yes, I can see the QR code.
Perfect.
Yes.
Thank you, Ray.
Thank you. We'll leave up the QR code for another 10 minutes, or 5 minutes, but feel free to just click through the link or copy it and do it later. Don't have to do it right now. Have a great evening, everyone. And I hope tonight's session was useful. Feel free to send us any questions. And as Nazia has mentioned, when the evaluation form goes out tomorrow, we'll attach some of the links to some of the really useful videos about ACT that Harsha has really kind of shared with us tonight. Thanks, everyone.
Thank you.
Harsha, I'd like to say just thank you so much for your participation, and it was really nice and I learned a lot. Thank you so much, even though if I wasn't active. I really appreciate it. I'd like to thank you once again.
Thank you so much, Nadia. My pleasure.
An honor. Thank you.
Bye.
Bye-bye. Thank you, everyone, for joining us today. Please feel free to just shoot any questions if you have tomorrow in the evaluation email. Thank you and have a lovely weekend. Bye-bye.